morning, everyone. This is my first time attending, so I'm really excited to see this group and meet you all. This is fantastic. So and real quick, do I advance myself? Okay. So I'm a research investigator here in Atlanta with Kaiser Permanente, Georgia. I'm a health educator by trade, and so a lot of the work I do focuses on intervention development, making sure that it's developed with the people who are the key audience for the work that we do. So just to get right to it, and we'll leave time at the end for about 5 minutes for questions. So, this is funded by Helmsley Charitable Trust and by NIDDK for us to do this research, both at Kaiser and Integrated Network and at Grady Memorial Hospital at their diabetes center through Helmsley. So I'm very excited to talk about what we're doing. And just to acclimate, all right. So I'm gonna get right to kind of breeze to the method, the focus of it. So this is a study that is a 3-year trial to really understand how we can take a behavioral intervention that's focused on reducing diabetes distress and really ensure that we are including people that have traditionally not been included in educational research and interventions. And so the goal is, aim 1, to really assess the feasibility of an intervention called TIDES that I'll tell you about, that's focused on reducing diabetes distress. And we want to make sure we understand, do people like it? Are they satisfied? And really understand some key metrics related to feasibility and implementation first. And then we want to look at the effects of this intervention among young adults, right? Some key diabetes outcomes. We'll talk about A1C, diabetes management, right? And hold on one sec, let me acclimate. I think this skipped a couple of slides. So I'm gonna leave this up, but just talk a little bit more about kind of the foundation of TIDES, right? So the ADA, the American Diabetes Association, has talked often about recommending that everyone with type 1 diabetes have access to proper education and support. And in some previous research we had done at Kaiser Permanente, Georgia, and I think common across not only what people experience with diabetes, but multiple kind of chronic conditions, it can be very isolating. And we started to see that there were young people that had never met another person with diabetes. We were working predominantly with Black young adults. We were finding they had never met another Black person with type 1 diabetes, so they felt very alone. And Kaiser has something called healthy lifestyle management courses. And when I went to the ones for diabetes, all of them were, I think it advanced without me touching it, and that's amazing. But I can keep going. But essentially, we found that the 4-series diabetes class focused predominantly on people with type 2, and that the educators would kind of poke around the room and say, does anyone have type 1? And they'd say, oh, this doesn't apply to you. Okay, but this applies to you. And so I could understand not only what we were seeing qualitatively, but also what we were seeing in the courses is that it wasn't really built for people with type 1. So there was an intervention called On Track, developed by Larry Fisher and his team with the Behavioral Diabetes Institute. Many of you may know them. But On Track was an intervention that we found that they found reduced diabetes distress, improved A1Cs for folks. However, right, it was developed it was a predominantly white, I think the average age was about 45. And so we started to see that it wasn't necessarily built for people who might be a larger swath of the folks that have type 1 diabetes. And so it wasn't built for emerging adults, right? It was predominantly focused on an older group of adults. So TIDES, yeah. Okay, how do I do it? Okay, it kind of advanced on its own. So I'm gonna actually move on to the methods though, given the time. So I think it just kind of advanced, which is fine. All right, so I'm gonna fast forward to TIDES is a study we're funded to do at 2 sites, Grady Hospital and with the Diabetes Center and at Kaiser Permanente, Georgia. Our goal is to recruit 80 young adults. We just finished our final baseline, we have 84, but we are working with Black young adults with type 1 diabetes who are 18 to 30 years old and really focusing on this group of emerging adults to, first, we worked with our advisory board to adapt an intervention, and then to pilot it in this feasibility trial. We did recruitment through emails, calls, texts, and provider referral. So we pulled our eligible list of participants from our EMR data, sent an email to providers the day of the visit, and said, you have someone that may be eligible for the study. And so that really helped nudge the providers to include folks in the study and offer it to them, because provider referral is really important because they do like their time with you all. So here is our consort. So again, it has the inclusion criteria. We do a baseline survey. We do a point of care A1C. We do, and on the survey, we do diabetes management, diabetes distress. We talk about social needs to try to understand folks' experiences and a few other key items, right? So we do 5-session intervention. We randomize people to either the diabetes distress reduction intervention called T1DES, or our comparison condition, which is Streamline. And one of our facilitators, Alicia, is here at Grady, who they love so much. Hi. So the Streamline standard comparison condition focuses on diabetes education, but also help with decision-making when things aren't going as planned, right? And so it really is trying to help troubleshoot as well. So to give you a little more about what T1DES is, T1DES is really focused on emotion regulation to help with addressing diabetes distress. Diabetes distress isn't something that kind of ends, or once you kind of figure out how to do it, you've terminated the need. Diabetes distress is something that you are battling and working through daily on a regular basis. And so the idea is, if we can first help folks understand some key steps to reduce diabetes distress, then you can help make room, honestly, for focusing further on your diabetes management, because there are multiple distressors that you think about. And so there are 7 key aspects to diabetes distress, and that include powerlessness, physician-based distress, family and friends distress, eating distress, hypoglycemic distress, and these different factors that are kind of constantly running through your mind as you're thinking about daily management, right? So the steps to diabetes distress are, first, you're going to recognize the presence of diabetes distress. It exists, right? So there's run, hide, and flight. But what you're trying to do is, and you have this different event that may have triggered it. So you tell your diabetes distress story. You express what you're experiencing. I feel, I think, I believe, right? And then you stand next to your story. I see that you, right? So you're reframing. I hear that you think that. I understand, right, what you believe. And so you're really helping with this shifting and reframing of how narratives have been built. You develop a more accurate and compassionate understanding and explanation for what you're experiencing. And then you can explore other options in your reaction to the stressors that you're experiencing, right? So, and I mentioned before, we use an advisory board. So we have an advisory board, not just of people who are members at KP, but at Grady, and we have some folks who are in other states who we talked to, we DM'd on social media, which is an interesting thing to do. You're like, I'm really not trying to do anything weird. I just wanted to invite you to our advisory board. But again, if you're working with emerging adults, we had to go where the people are. Apparently Instagram's old now anyway, but we started on Instagram. But we worked with an advisory board to help really adapt the portions of the on-track evidence-based intervention that did not apply or resonate for young adults. And so this is an example. They there was an existing narrative, but they shifted the narrative to be applicable. So you have Kiara, who is experiencing some key challenges with her management. She's working really hard to manage her diabetes distress. And I think it's really key that our advisory board made sure to say, listen, I'm working, right? This is important. My numbers may not be where you want them to be, but I'm working on it. So the A1C has dropped from 9.5 to 8.2. While some people may say that's not the goal, right? We have to celebrate every step in the success, right? And that's really important too, to make sure it was seen. The doctor says, but your A1C is still too high. You really need to exercise more. Well, haven't you been exercising, right? And Kiara says, I guess I'm lazy, right? That's that first narrative. And so the goal is to shift it. And the doctor says, but you need to try harder. Right, so this leaves feelings of being defeated, discouraged, and then, this is kind of the old cycle that we're trying to help think, how can we shift this? So we have, in the program, this is then kind of laying out the story for folks in the intervention. And I'm going to get a little further through, right? And so what's important is in the TIDES program, we want people to feel seen, and then we work through the steps. It's facilitated by a psychologist who has been trained motivational interviewing, a lot of helping let the participants in the study lead and make sure their experiences are there. And there's the impact of them learning from one another too that's really key. So TIDES emphasizes this group effect, and our comparison condition kind of de-emphasizes that as well. I went too far. I don't know how to go back. But what I wanted to highlight is there's an ASAP method. It's well published. Larry Fisher and his team publish it. We also will talk about it. But the ASAP method, I just want to encourage folks to check it out because it's a really, really great tool for thinking about how you, for thinking about how you can help engage people in the intervention. Everyone has challenges getting places, doing things, fitting it in their schedule. So I think it's just helpful to train your teams to think about, well, how can we help you get there and how can we help you engage? And so this is anticipate, acknowledge, standardize, accept, and plan. Right? And so we have that a lot. And it's so interesting. Some of our folks, I think, do it naturally, but I think it's helpful to see it in writing. And then we created this little script for our research assistants. So, hey, if someone says they can't come, like, oh, can you tell me what's going on? How can we help you work through that? Well, we can reschedule you for the next one, or can we help you get transportation? Or what are some of the things that we can work through? Right? So in the study, as I mentioned, I just want to highlight the different feasibility and outcomes measures that we focused on and measured, guided by the REAIM framework, right? So as I mentioned, we've done our baseline. We've completed our baseline. We enrolled 84 people, young adults with type 1 diabetes in our study across both sites. So we met our recruitment goal, and that was about 2 months ago. So we're very excited to be able to share some of the baseline information with you, right? So what's important to understand is our average age at baseline, about 24 years old, but our full range was 18 to 30. Average age at diagnosis is 14.1, but I want to highlight that range was from 2 to 27. So you have people that have been managing and living with diabetes for years, and you have people that were newly diagnosed with it. We didn't include anyone that was newly diagnosed within a year, so they had to have a diagnosis for at least a year, right? Because we wanted them to have time to acclimate, at least with their providers, right? So again, everyone in our study self-identified as Black, so 100% self-identify as Black. And I just want to note that also about 18% also were multiracial, right? So we know race, there's self-identification and there's, I think, your technical makeup. So our sample was 62% female. Education, about 54% of our sample had some experience with college, associate's degree, bachelor's degree, or graduate degrees. All right. So aim one is, do they like it? Will they come? What do they think of it? And so we had really high satisfaction scores across both our TIDES intervention and our standard of care. They loved coming in, talking with each other. One of the things I always talk about, when you have a group that feels very isolated and you bring them together, one of the things we find is I don't even know if in the end we'll find a true difference between our Streamline and our TIDES intervention, because we took people who hadn't met anyone else and brought them together. And I think there is just something to being in a room and not being alone for the first time and looking around and seeing people who look like you, and that's important. Because treatment is one-on-one. And so we're just thinking about how we've emphasized the group effect for our group and how much they enjoy it. And this is for people who said the group was excellent. I really enjoyed it. But when you look at people who said excellent or good, right, they love it. They enjoy it. They're coming. And so I just want to highlight it's important to think about, when we first put this in, some of the reviewers were like, well, I don't know if you're going to get people to come to the group. And I think we can. I think you offer them an opportunity and they lead, right? And so this was one of our exit interviews. A participant, talks about their experience. And not on here, we do have someone else that said, listen, the facilitator made us feel like just do that one thing you did was important, right? And you can focus on the next step, right? So just one bite at a time. And but I really love these quotes because they talk about getting to meet other diabetics. And there are other people a Black young woman with type 1, I met someone else, right? And feeling represented and just being in the room together was important, right? And so we often talked about in our intervention something that our advisory board called a double, they were saying it's really like you have this like duality of both being Black and type 1, right? Oops. So I have to, it's like 5 minutes. But being Black with type 1, especially I think living in the South where type 2 is predominant, right? A lot of people feel like they have to manage up, and that's exhausting, right? So no, this is not what type 1 diabetes, this is what it is, even within their own family. And so there's just a lot of feeling exhausted by that. And so one thing I also try to do is think about how can we help alleviate that burden for people who are getting treatment for type 1, and how can we as like a healthcare system and as a health educator, right, what is it that we can do to help kind of lift some of that so that we can help them not have to manage up everywhere they go. And that came up yesterday in a session and I loved it. So again, to our aim 2, looking at some key diabetes outcomes, and just to kind of orient your eye, this is a table of some of our key outcomes with the full sample, and then again by condition, TIDES and streamline. Because this is our baseline, we're just kind of looking at where folks stand. And so for A1Cs, our average A1C across groups was about 10, which, we've actually seen, that's one of the key reasons when I got to KP, we really wanted to think about how can we help get A1Cs down, right? That, I feel like endos, you all are seeing people, and we found that people enjoy it. We also found that some of them are just exhausted, worn out, and need help talking through what's going on and finding a group. And so we're hopeful that, I don't know if we'll see change in A1Cs in a shorter intervention, but we do also see that, right, diabetes distress is key for folks. Diabetes distress score of 3 with this measure is actually an indicator of high distress. And we saw also high distress, I mentioned there's 7 subscales. Some of the key areas where we also saw high distress, not just with the total score, were management distress, so that feeling that you can't give your diabetes as much attention as you should. Hypoglycemic distress, right? Feeling that you'll never be safe from the possibility of a serious hypoglycemic event. Powerlessness was key, feeling no matter how much you try, right? It will never be good enough. And then eating distress was another one that had high distress scores. So feeling that your thoughts about food or eating control your life and they're running things. And so you can understand, and so these are just the ones that were high, the others were moderate, right? And so it's important to understand that a majority of people with type 1 diabetes are going to experience some form of distress, throughout their journey and experience. And so we want to think about how TIDES could be helpful and additive in reducing, or providing a tool so that when you feel those likely distressors, you're able to manage. And then I also wanted to highlight social needs. So it's really important that we think about some of these other factors that are going to be pressing and instrumental for people as we're also trying to navigate healthcare. You're trying to, navigate these instrumental needs like finances, housing, utilities. And so on average, we found that out of kind of 7 different social needs, people had an average about 2.4. And so at any point, they're kind of trying to figure out these other areas. And we also wanted to look at what is interrupting or could be obstructing their ability to manage, and finances are key. And so when you have folks saying, when you have A1Cs that are high, it's not that people aren't trying, it's that there are so many layers of needs that people have to address in order to be able to manage what they know needs to be done. And so you'll see here just some examples of people saying that the cost of insulin kind of caused them either delay or skip their doses. And so that was key too, because at KP, some of the endos were surprised because they weren't hearing this in their sessions or in their time. And so here it just is built out more specifically how folks responded to questions about social needs they may have in the past 2 weeks. And so the darker blue icons are for people in our TIDES condition, the lighter blue are for folks that were in streamline. And so you can see food, finances, transportation were the most reported across the board, followed by social isolation, housing, and utilities, right? And so this was key for us because we also have to think about how these are likely we have to build our interventions and factor in that this is going to be key for people getting to each other, getting to endos, getting to health education, just getting around. These are what they're experiencing. Okay. So just closing, this is the last slide. One of the key things I keep thinking about as a health educator who's mostly community-based, healthcare services is semi-new to me, right? How do we sustain outcomes? How do we sustain programs? Where do they live outside of research, right? I don't want to do it and leave. I want to figure out where it lives. And so the next stage is to figure out, one, how can we help people maintain the outcomes we find? And two, where does it live? I think this is done with clinical collaboration. I work at KP. I look at all the different ways in which health systems are embracing prevention and education. And so my goal is to figure out what's next, how do we implement, and where does it live, somewhere that's going to be in people's lives long term. And also maintaining that community connection for people with type 1 diabetes, and thinking about how can we use programs like the Diabetes Link has Discord and all these other channels and avenues where people can connect and keep them engaged. And also making sure that we keep the patient voice key, right? People with type 1 diabetes, nothing for us without us is like the way I treat every intervention we work on. So making sure that we have advisory boards functioning, involved, engaged, that we're always checking, is this still applicable? Is it still representative? Is this still representing what you experience as someone with type 1? And that's it. Thank you.
We have a couple minutes for any questions.
Can we go back to I saw someone taking a picture. Can we go back to yeah, thank you.
Hi, Tina. Thank you so much. I really appreciate your talk. This is Marissa from Children with Diabetes. And my question is, and this is something I think I was speaking with someone else with diabetes here about yesterday, is that many of us living with type 1 sort of have this baseline diabetes distress, if you will.
Yeah. Okay. It's like a low hum.
Exactly.
Right? Yeah.
And many of us would not sort of self-identify as having distress. And I wonder how you overcome that.
Yeah, that's a good question. I think what's interesting is one of the reviews, we had to submit this 4 times to get funded, but one of the early reviews said, well, are you going to assess diabetes distress upon entry? And I was like, no, because 95% of people have diabetes distress at some point. It's not a stable trait. Right? Anything can impact it, and it's very dynamic, and so absolutely not. I think it's good to understand people's levels of diabetes distress, but I wouldn't screen people out because at one point they don't have it, right? Things shift. So yeah, I think it is key, right? Yeah.
So yes, I echo Marissa, and thank you for this talk. Yeah. When Type 1 Diabetes Exchange was looking at diabetes distress as one of the measures, we did a small pilot at Cincinnati Children's, and we weren't actually finding diabetes distress in what we perceived to be our highest distressed patients.
Yes.
So then at that point, we were like, are we measuring what we should be measuring, right? Are we asking the right questions to the most vulnerable patients, which again, a lot of times, unfortunately, ended up being our marginalized communities, including Black and Hispanic communities.
Yes.
And then we even did I think it's the parent distress one too.
Yes.
And I had a specific family, I know this mom, I'm friends with this mom, she's a helicopter mom, she's a cop mom.
Yes.
And neither the child nor the parent identified themselves as being such. So I was like, what's going on? What's going on here? Were we not measuring the right thing, and did we need to come up with different measures?
It's interesting. I think also when you've experienced something for so long, you don't recognize it because you're like, oh, that's just the low hum. That's my baseline. But I also think too, it's the wording. Sometimes, even when I look at our measure, we use the T1DES. We also looked at the Youth Diabetes Distress Scale. I think what's important is, I think it'd be better if there were quotes. Have you ever said these things to yourself? Because if you ask me like to sit back, there's certain times I'm like, oh, I don't know, I guess. But if you ask me, if you give me a quote, I'm like, yeah, I say that all the time, right? So I do wonder sometimes, and that may be a longer survey, but yeah, I think some of it is how we ask.
This is Andrea Mucci from Cleveland Clinic Children's. I really appreciated your talk.
Yeah.
I have a more generalized question. So I love the fact that you identified that just bringing these people from marginalized groups
Yes,
together,
yes,
whether
yes.
you have the intervention or not.
That's right.
Thinking of our department, we don't necessarily have providers who are representative of our patient population. And I'm just wondering, like, if I wanted to do something like this, do you have any recommendations how we as non-representative providers could provide a safe environment for these individuals?
That's a good big question. So a couple of things. One, I often think about when we scale this up, where does it live? Because the in-person impact is so key that I think the first thing I go to is, well, if we make it virtual, we can open it up to more folks, which is absolutely true. But I also think we still have to bring people together. And so I'm always trying to think of, like, how can we get into a conference and meeting? Like, what can we do to bring people together at some point? I also think it's key to then tap into, like, if you have a parent or a patient advisory board, if not, get one. And I, like, love talking about how to pull together advisory boards. So, like, definitely let's talk. The other thing I think about is sometimes naming the elephant in the room. Like, hey, I understand, like, I would love this. I want to hear more about your experience, even though we don't have anyone here who looks like you. I'm ready to hear. And so also some of it is just making sure that we think about how we've approached it. Do they have other, like, who they have that they engage with? Like anyone, even if it's not a provider, but do you have anyone on your team that might be able to be a great kind of front of the house person for folks as they kind of enter your shop? Okay. Oh, sorry. And I was going to say one other thing. One of our advisory board members is really, really passionate about getting more endos, people who support people with type 1 diabetes as providers from medical, like, go to HBCUs and recruit, go to them and talk to Memorial School of Medicine and all of these HBCUs that are producing the largest number of scientists, Black scientists, like, go get them, right? Bring them to your shop. And so she's really focused on getting more providers to, like, camps for kids with diabetes who are Black, right? So I think that start the pipeline as well. So, okay, that's it. Thank you so much.